we come across a situation that is difficult to treat. So these are a mix of cases which are either a diagnostic challenge or are a therapeutic vision to difficulty in recognizing the relatives at 1 meter, and she was recorded to have a blood pressure of 250 by 120 5 days prior to coming to PGI, and she was in each because of the vision problem. She was seen by Professor Gupta. She did have diminution of vision. He noticed that there were some cells in the anterior chamber and there was some posterior synecdoche. But what they saw on the fundus examination is being projected here, and you can see that there were disc edema, there were hemorrhages around the disc, and there was some macular scar formation. So in somebody who's had a recent blood pressure of 250 at such a high blood pressure and a vision loss, she was referred, because I work in collaboration with the UAD's clinic people, she was referred to us. But when in a diabetic, as a physician, you ask the history of chest pain, she did have chest pain, although it was atypical. There was also dyspnea on exertion and there was dry cough. But generally, her blood pressure at the time when we saw her was normal, and the CNS examination was normal, except for the fact that we've shown the fundus, what it showed. If you look at the ECGs carefully, if you look at the top ECG, it showed that there was ST segment depression in the leads, the lateral chest leads, which after 6 hours you can see the T waves have normalized. In a diabetic and hypertensive individual with dynamic ECG changes, you would consider that it is an acute coronary syndrome, and our neurologists were brought into the picture by that time, and it was presumed that with that kind of a fundus picture, it's a malignant hypertension. But the thing which didn't explain the picture in totality was, why did she have a painful vision loss, and why were there cells in the anterior chamber? There was also a history of chest pain and dry cough. But as she was a sitting MLA and she had this pain, she was immediately wheeled into the coronary care unit, and cardiac enzymes were done, everything was normal, the echo was normal, and the chest X-ray was done. We did show there was some hilar adenopathy, and we did request the cardiologist to give permission to do the CT, which we were allowed to 2 days later. And then what it showed was that there was, because we thought that this is not really merely a malignant hypertension, but this could be something which probably, the CT did show there was mediastinal adenopathy, and the chest HRCT, some of the pictures which were shown previously showed that there were interlobular septal thickening and the disc edema, and we went ahead after the cardiology clearance that it was not an acute coronary syndrome, but it was a non-compact, non-caseating granuloma in a patient with sarcoid involving the optic disc and a probable pulmonary and a probable cardiac involvement, because there was no coronary event. So this was a patient who seemed to have malignant hypertension, eventually turned out to be having sarcoidosis with optic disc edema to present with, and if you see carefully, there were some granulomas which the ophthalmologist called with pulmonary and the probable cardiac involvement. So as we were discussing, it may not be as cut and dry as we presume, that we can just make a diagnosis only on the basis of radiology.
Can we discuss right here?
Yeah, why not?
So, what was the cause of such severe hypertension in this lady?
Such severe hypertension could have been because of uncontrolled blood pressure or stress, or we don't know whether it is correct or not. But if we go back in time, and if I could discuss it, you see there is why should a malignant hypertension have a painful, progressive vision loss? And the vision loss is for 20 days, and only isolated one reading of 250 by 120, whether it was a stress or one-off phenomena, it was never reproduced again, and the EC doesn't really show left ventricular hypertrophy. So we don't know, but when we saw the blood pressure was normal, and it didn't show other changes of hypertensive retinopathy as you've seen. So we don't know about that, but the red herring was she did have a documented blood pressure which was high, but that's precisely what we need to do.
She was already a liver patient of hypertension, so she can have.
She can have once in a while, she can have uncontrolled hypertension.
So that means you are trying to explain the patient with two diagnoses rather than one.
Possibly that was
the disc edema is not malignant, because the day we gave steroids, next day the vision became normal, and the papillary edema won't really disappear with steroids. So we had a heated debate with our neurologist, and what we told them was that if we presume that papillary edema responds to steroids, why not start treating all patients of papillary edema with corticosteroids? Because from almost losing vision at 1 meter, she started seeing on day 3, which would only happen with the sarcoid granulomas melting away. Says, I'm happy that we are having some discussion going on here. And if you see this disc carefully, if I could have the pointer, and if you see there are granulomas sitting over the disc, which never happens if you see somewhere here, this is quite characteristic of sarcoid involvement of the disc. You see this white thing here? So you see this white thing here? So this is a disc involvement with the granuloma sitting over the, presumably granuloma sitting over the disc. So if you look at the international classification of ocular tuberculosis, now it has been included as a part of the ocular sarcoidosis. So it's not as, so something which from the surface it seemed like malignant hypertension was absolutely entirely different, and it was not really malignant hypertension.
What of HRCT?
Because this,
Is it not a sarcoid or?
because the X-ray did show there was some hyaluronidopathy, and we went ahead because the cells in the anterior chamber with disc edema, we did think about sarcoid, but our cardiology colleagues unfortunately were not agreeing in the beginning. The patient was in the coronary care unit, but then eventually they had to agree that this was sarcoid. We did keep a possibility because the hypertension cannot present with anterior chamber inflammation. Can't have cells in the anterior chamber. ACE levels are normal. Although he would not have done the ACE levels because, as I told you, in the initial 4 or 5 days, the patient was in another coronary care unit. They thought that the ACE levels should be done if you are saying it is sarcoid, but it was not elevated. So it again proves the point that they have no role in making a diagnosis. So even if your friend or colleague saying you get the ACE levels done, you should not do it actually.
Another red herring was that this was a patient with so-called hypertensive encephalopathy, but normal blood pressure.
That's
Only one reading was high.
There was no encephalopathy, only vision loss.
Right.
There was no encephalopathy. Patient was walked in with support, but there was no encephalopathy, only elevated blood pressure and a vision loss. No encephalopathy.
How to explain ECG changes?
That's what I said. ECG changes because of probably cardiac support. The enzymes are normal.
That was the thing.
normal. Serial cardiac enzymes are normal, and then we did a cardiac scan also, and it didn't show any perfusion defect. Now it didn't show any perfusion defect. Only then we were allowed to do a CT and then go ahead and do the CT TB allocated.
Those specific STD changes have been found.
Sarcoid can have all kinds of cardiac involvement. They can have conduction abnormalities. The granulomas can be there in the conduction system also. And then you can have ECG, all kinds of ECG abnormalities have been reported. Dr. Wonder is sitting here. Although if you do a biopsy, you may miss out on some of those findings because even the endomyocardial biopsy findings are only 30% sensitive.
So these sort of changes, please, in the both the leads could happen because of electrolyte imbalance also.
There was no electrolyte imbalance. No hypokalemia.
There is a request from Dr. Soni that if this goes on, then this remains case 1 only. We would not go into the other cases.
I can stop at case 1. We can have the discussion.
Yes, no problem. But the interest here is that what he is trying to point out, let's pick up, there were these subtle changes which generally we would be ignoring in a context, and so he would be discussing. Please jot down and then we come case to case rather than discussing case 1 or case 2.
Yeah, I will be happy to answer any questions on the podium and off the podium also.
That's what. But Dr. Soni needs to answer everybody because we are falling short of time.
We've spent 10 minutes on the case 1, so let's see how many we can discuss. Good. This was a biopsy-proven patient which responded to steroid, and I think that we had a same heated argument in Iacmcon, and eventually we proved to our neurology colleagues and others that this is sarcoid and nothing else, and I'm happy that that trend continues even here.
Just a comment.
Sir. A young man was referred to us a case of DVT with pain and swelling in the lower limbs, and then there were, besides the DVT, comes to the emergency area. One thing which is shifted to the ward, besides the DVT, is having oral ulcerations. As you can see here, there are scrotal ulcerations, and if you could see, there is a superficial thrombophlebitis, there is a pseudofolliculitis, and the one thing which he didn't complain was a vision loss. He was a tailor from Saharanpur who was working on a swing machine which is used with the feet, was more concerned about the DVT but not really concerned about the vision loss that he was having, and eventually we proved that there was IVC thrombosis. But the other thing which was missed were there was hypopion, there was even a posterior hypopion for those who are familiar with seeing the fundus in both the eyes, left and the right eye. So the question in front of us is, there is a patient who has come with DVT. This is only one condition in which you do not give anticoagulation even if there is a DVT. Because the thrombi are supposed to be adherent to the vessel wall, and these are the EULAR, European League recommendations. that if it is a vicious disease, which this patient had because of the oral ulceration, genital ulcerations and the skin changes, even if there is a DVT, unless it is IVC or there is a previous pulmonary thromboembolism, the European League recommendations are these are the patients who do not require any operation. So that's the message. This is a therapeutic challenge, and this is this is the treatment information that I would like to share. Some people believe that we don't have patients. This is our own data from Ugandis clinic. We now have more than 100 patients for patient's disease on our follow-up. Another patient, a young man with back pain, carrying as usual. By the time they reach here, they have multiple X-rays. So this is the question to the audience. Can you pick up what the abnormalities in the lumbar spine X-ray? Yeah, excellent. We heard from the right side, this is a disc calcification. This is what you need to pick up. And then you look at the eyes. Look at the eyes more, look at the sclera more carefully, and the palms and the hands. And the diagnosis is written there. Instead of having 100 X-rays, if you look at one X-ray carefully as we heard from the right side, and this is what happens, you just keep the urine there and see the change of color. This is prognosis. So they're not very difficult. Another patient, who again comes to the joint disease clinic from Nepal, having visited various centers in India. But historically there was no morning stiffness, and her mother had died at the age of 40 years. So possibilities after having seen these fingers and hands. Rheumatoid nodules, gouty nodules, anything else? Now? Yes. Tendon xanthomas, planar xanthomas, tuberous xanthomas, eruptive xanthomas, palmar xanthomas. This was a arcus annulus, xanthelasmas, familial hypercholesteremia, and she did have some disability in extending the fingers. And you can imagine, from Nepal she has visited various centers and comes to PGI, comes to the joint disease clinic for a disease which doesn't really relate to rheumatology. So this is familial hypercholesteremia. Another lady, fever, some pain in the ears, some pain in the joints, loss of appetite, loss of weight, started on ATT, which is not unusual in this country. But look at these ears. The nose. Excellent. Decruiser. There were tracheal cartilage tenderness, there were erosions in the thyroid cartilage, and there was airway involvement. So this is a diagnosis of relapsing polychondritis, and although it's supposed to be a rare disease, we've seen more than 28 patients, although 800 patients have been reported in the world literature, and we've also made a disease activity index. So it's not that they are not there. Or one would see, we've seen around 28-29 patients till now, and we had one patient who had a sudden airway collapse which responded to steroid, central airway obstruction with left main bronchus obstruction also, which we treated and documented on bronchoscopy that it was reversible. Another patient from Ludhiana, biphasic illness, presented with young boy, very smart, sick boy, very beautiful boy. Came to us, Dr. Bambri had made a diagnosis of reactive arthritis when he presented with ankle swelling. SPA was considered, sulfasalazine, statin and steroids. By that time he left, he went to Australia. He came back again in September to me. After URI, he had pain and swelling of the wrist region, but this time no morning stiffness. I'm emphasizing again, ESR was normal, CRP was also negative. We increased sulfasalazine again, gave some steroids, thought that the disease is coming back. But look at the hand on the right side, severe burning pain. I would request the practicing rheumatologist to just give the opportunity to other people if they can make a diagnosis. Severe burning pain, hyperesthesia, swelling of the hand, hyperpigmentation, fingers in the flexed posture, and such severe pain. Look at this hand.
Sympathetic osteodystrophy.
Yeah, this is complex regional pain syndrome, which caused, and we did a triphasic bone scan, and it take almost, we started treating him, didn't respond, had to hike up the steroid with carbamazepine, amitriptyline, gave zoledronic infusion, and over a period of time, took a while before, it's May of 2008, with physiotherapy and treatment, and the father was so happy to send a mail that this boy in December and January could not wear anything over the forearm. because there was so much aerodynia that he could not even have shirt over his forearm in December and January in Ludhiana. You can imagine how much aerodynia was there. Another patient, again, keep this thing going. Young lady, we've seen this last month who had presented in our staff clinical meeting last week. Young, joint pain, small and large joint arthritis, photosensitivity, oral ulceration, synovitis, documented, systemic examination normal, some of the joints showing some swelling, some MCPs and PIPs. So what are the possibilities that come to your mind? First thing, photosensitivity, oral ulcers, arthritis, young lady, 1 year. First possibility comes to one's mind is N is negative. Hemogram is normal. Next possibility, rheumatoid arthritis. Rheumatoid factor is negative. But is it seronegative rheumatoid arthritis? We do a chest X-ray. Now, hyaluronidopathy. What comes to your mind? Sarcoidosis. Okay. AFB positivity. This is the genuine original slide. AFB positivity. Patient started on AKT. So, don't believe what appears either on clinical medicine or radiology. So, we were talking about concepts. I'm happy we published this. It was available last year, so I think it's published now, last month. This first series from India, and there were no diagnostic criteria. We proposed diagnostic criteria of concepts also, and there are almost 230 patients in the literature of Ponson's disease. There were oral ulcers and genital ulcers also. We had previously reported a patient who looked like Behçet's disease, oral ulcerations, genital ulcerations, but the catch was the genital ulcers here were on the penis. Whereas in Behçet's, as I showed previously, the genital ulcers are on the scrotum or cranioscrotum junction. They are never on the glands. So what we did was, we did a biopsy from this. These were papillonecrotic tubercles. We did a biopsy from there. We did a biopsy from the skin lesions. Did a TB PCR. Proved that it is TB. Gave it TB. This patient was referred to me because some people know that I have got interest in vasculitis. The skin lesions were biopsied and it showed lymphocytic vasculitis. And he was already prescribed endoxan along with methylprednisolone when he chose to come to PGI. At that time, even when we made the diagnosis and just gave him ATT, and this patient had a joint disease which is going on for some time, maybe a couple of years. Another patient, young female, progressive shortness of breath, generalized body swelling, left ventricular ejection fraction 15 to 20%. The patient had ascites and effusion, and our resident, this was labeled as postpartum directed cardiomyopathy by the resident who presented the case to us. And she said that, sir, I don't know why somebody has done an ascites tab and it shows high protein ascites, although it is a clear-cut case of postpartum directed cardiomyopathy. But which in this dramatic history of cardiac failure and low ejection fraction, what the resident missed was that there was history of low-grade fever for almost a year, and by the time the patient reached PGI, patient had weakness, there was already an early foot drop. So the initial things that we thought was because of high protein ascites, we thought whether there is veno-occlusive disease or there is Budd-Chiari, and when we did a CT angiogram and we asked for the nerve conductions and a nerve biopsy simultaneously and a skin biopsy, to our surprise, you see there was a hepatic infarct. And one of the hepatic veins was absolutely occluded and the middle one was attenuated. And we did a skin biopsy, we did show vasculitis. You can see the vessel inflammation. I'm sorry, I cannot point it out. And even in the nerve biopsy, if you could see the vessels toward the margin, they also showed vasculitis. So this which was labeled as a case of postpartum dilated cardiomyopathy, was in fact a case of classical polyarteritis nodosa with mononeuritis multiplex, dilated cardiomyopathy, digital gangrene, and we did a lupus anticoagulant was also positive in this patient. We did publish it, and we treated the patient with steroids and cyclophosphamide. There was improvement in the ejection fraction. She had a mini relapse later on, for which we did have to do a reinduction, and the patient subsequently improved. She is the wife of a helper working in a sweet shop in Patiala. And this is the guy who I have seen one of the most intelligent, although illiterate patients. He would do INR regularly and follow up, and the patient had a perfect follow-up. And I think it's now almost 7 years follow-up. Patient is off all therapy. As we know, the PAN is usually a single shot MS. Another patient which leads on to, makes us think to have a relook on what has been proven. This was a lady who was having bloody diarrhea for 3 years. Labeled as ulcerative colitis outside, colonoscopy showed ulcers in the transverse colon, ascending colon and sigmoid and cecum. There was a biopsy done which showed them ulcerated lining epithelium with total loss of crypt. There was some mixed inflammatory infiltrates, and she was started on steroids in Mexico. And the only thing that we know in history was that whenever the steroids were tapered, her symptoms would go up. She presented to PGI with massive lower GI bleed, multiple blood units had to be transfused. We did a RPC scan which showed an active bleed, and surgeons were kind enough to take her up immediate for urgent surgery. And since she was in hypotension, total colectomy and distal stump closure was done with an ileostomy. And if you could see, there is a granuloma sitting in the vessel here, and there is a fibrin here. So there is a fibrinoid necrosis of the blood vessel, along with a granuloma in the vessel wall. So you can turn around and say that the Crohn's is also, it may not be ulcerative colitis, it may be Crohn's. But what was not there was that in the uninvolved areas, there was no cryptitis, no crypt destruction, nothing. And then we asked our histopathologist, we could get the blocks of the previous biopsy. There was no evidence of inflammatory bowel disease in that biopsy, and what it was isolated granulomatous GI vasculitis.
Aman, I'll request you to give some time for the discussions also, because you will have
Right.
a lot of discussions, you know.
Right, sir. So this was isolated granulomatous GI vasculitis. The last patient came with fever and neck pain, carpedinia, went to various specialists. The carpet was tender, we got a PET scan done, and it was Takayasu arthritis. So there are various clinical vignettes. If those of you with challenging cases can refer this book, and this is a conference in the clinical medicine, I would like to conclude that the key to good outcomes as far as diagnosis and therapeutics is the true practice of clinical medicine, which is good history and detailed clinical examination. Thank you very much for your attention.